Thank you very much to the scientific committee to allow me to share with you this preliminary experience about very low loss microwave treatment. And the prerequisites to be able to apply such an energy with great accuracy was to have a tool for aiming. That's what we have with what has been defined as an all-in-one system for cartography of the patient. It's the well-known Trinity platform, which is allowing a lot of maneuvers around the treatment of prostate cancer, from diagnosis to surveillance and monitoring. And one of the main things is the ability of the system to take a record of the previous biopsies in the area and to use the platform as a tool for monitoring, for example, surveillance, as it has been shown here in a follow-up of a HIFU patients by André Abreu and by others before him. And the precision evidence of organ-based tracking is in the range of 3 millimeters. It's been shown by several papers, and it allows a very high accuracy of revisiting cancer, as been shown 5 years ago already by Osamu Okimura. So that finally, what really matters to apply a treatment thereafter is that previous course can be targeted with treatment needles at the very same place. The energy we need for such an application must be predictable and repeatable, quick and efficient for tissue ablation and also for clinical use in the real life. There we have to obtain a sharp delineation between the treated and non-treated areas, as been shown for most of the modalities so far. It must be compliant with all tumor locations and may be able to deal in particular with the anterior tumors, which remain very often a problem, and allows also for retreatment, because it's just heat dissipation without further important consequence. So that microwaves have been used for a while, and their main drawback was that there was generally surrounding the generator very quick dissipation proportional to the diameter of the transducer. So that in the very beginning of these applications, which dates back already to more than 20 years, many transducers were needed to surround the lesion in order to add their effects and avoid the drawbacks of the dissipation. And what makes the difference is the development since 2014 of a new type of transducer with eventually a multi-application, but it's not really needed, with the shape of the single needle, which is now avoiding this problem of dissipation very close to the diameter of the transducer, so that it allows in the ex vivo, it's been very widely studied on the animal muscle or animal liver, and the conditions of firing regarding the time and the power have been extensively studied and could be applied in a preclinical setting to show that finally we could, with some reliability and reproducibility, obtain in a very short time, with regard to the clinical application of 2 to 5 minutes, we were able to obtain a very consistent ellipsoidal shape, which enables to deal with a small tumor in the field of focal therapy. And in the low part of the picture, you see the shape of the templates that were obtained on different kinds of tissues, from muscle to liver, but not yet, of course, on human prostate. So that when combined to a further development of the Coeli software, it's enabled to contour the area to treat in a real way and define the margins to treat beside it in order to deal with the fluence area around the treated volume and also to eventual positive biopsy nearby the main region of interest. There was also in the software a visualization of expected treatment effects so that a nice match could be done in virtual firing to cope between the treated volume and the lesions. And finally, of course, everything was recorded and post-therapy image fusion could be done. So we carried out 2 phase 1 studies, one where the primary endpoint was, of course, the control of...
Let's come to your conclusions.
Yes, I had assigned about 2 minutes just 10 seconds ago, so time's running. So the assessment was done in Paris through MRI at 6 months and biopsies at this time. And they showed 80% rate of complete necrosis, a partial ablation in the remaining patients, and a good matching with the ablation charts on T1 DCE at day 7. In the meantime, in Brussels, we did an ablate and resect study on 10 patients in order to have an histological validation on macroslices and then on the whole mount prostate. And we can conclude that to reduce the number of sessions for the patients, we did the treatment at the time of biopsies in a population of patients with Pirates 5 lesions. Surprisingly, 2 of them were negative at the time of the checking for the biopsies in the target, so that 6 microwave treatments were applied and obtained the same characteristic as done in Paris. No side effects and same-day discharge with local anesthesia and just sedation. For what regards the quality of life, no difference with the baseline at 6 months, assessed by self-administered questionnaires by the patients. And what regards the discussion, so far we have some question about the discrepancy between the ablation charts and the lesions seen on the control MRIs at a distance. And we still have to solve these problems and eventually get quieter about the true effect. On the right lower edge, the area which raises questions remains, of course, the intermediate area between full necrosis and non-treated area. Finally, beside the fact that we have the tools for aiming, we still have to assess in a phase 2 well-conducted trial the endpoints that I already mentioned on a larger scale, and that's why we are nearly starting a clinical validation in a phase 2 multicentric trial. Thank you for your attention.
Thank you. Thank you.